Thank you very much. It's a great pleasure to be here today and also with Dr. Zelenitz. I welcome our entire audience. Thank you for joining us. I hope everyone is doing well and staying safe, and I'm looking forward to today's virtual challenging case clinic on transform lymphoma. I'm John Leonard. I'm a Senior Associate Dean and Professor of Medicine at Weill Cornell Medicine and New York Presbyterian in New York. And I'm joined by our presenter today, Andrew Zelenitz, who's Professor of Medicine, Medical Director of Quality Informatics, and a lymphoma specialist and researcher at Memorial Sloan Kettering Cancer Center in New York. So, Andy, thank you for joining us today.
Thank you for having me.
I just want to let the audience know that our activity is supported by independent educational grants from AstraZeneca, Bristol Myers Squibb, Pharmacyclics, and AbbVie Company, and Janssen Biotech Incorporated. The activity is provided by the University of Nebraska Medical Center and BioAscend. We thank them for their support and organization of the program. This slide summarizes some of the continuing educational details of the program. And it's important to note that University of Nebraska Medical Center Center for Continuing Education will award one Category 1 credit as summarized here. And the program has been planned and implemented in accordance with the accreditation requirements and policies as noted on the slide through the providership of the University of Nebraska and BioAscend. This slide summarizes a variety of disclosures relating to the requirements and organizational features of the program in relation to particularly conflicts of interest and off-label investigational uses in accordance with appropriate guidance. This slide summarizes our faculty disclosures. Mine are on top and these are on the bottom, and I suspect that some drugs relating to some of these companies may come up in our discussion today, and so you should be mindful of that as you listen to the presentation. So the objectives of the program are to talk about and evaluate the best available evidence relating to treatment for transform lymphoma, assess emerging clinical trial data regarding transform lymphoma therapy options, and develop strategies to address complicated transform lymphoma cases. And this program is part of a series of a number of programs that may be of interest to you. We invite you to visit oncologycaseclinic.com to register for upcoming webinars and to take a look at archived past webinars that might be of interest to you.
John, thank you for the invitation to talk about transform lymphoma today. So why don't we start with some definitions. The change from an indolent lymphoma, such as marginal zone follicular lymphoma, small lymphocytic lymphoma, chronic lymphocytic leukemia, to an aggressive phenotype, most commonly diffuse large B-cell lymphoma, but can be high-grade lymphoma or Burkitt lymphoma. Often people automatically use the term Richter's transformation for all of this, but Richter's transformation should be reserved for transformation of CLL to an aggressive lymphoma. And it's really essential that we have an adequate and appropriate biopsy, though there are some circumstances where people might proceed with a clinical suspicion of transformation, but it is best practice to confirm the diagnosis of transformation. Okay, so let's go back one slide. There has been a lot of data regarding the molecular features of histologic transformation. If we look at follicular lymphoma, which is the most common indolent B-cell lymphoma and the most likely to transform, we know that we have B cells that have a 14-18 translocation They are not necessarily malignant or follicular lymphoma yet, but additional mutations accumulate. CREB-BP, a mutation of MLL2 and EZH2 are early mutations that often are associated with clinical manifestation of follicular lymphoma. We can get a variety of progression mutations, but when we start to see mutations, particularly of translocation of MYC or mutations of P53 or CDKN2A, these are strongly associated with transformation from an indolent to an aggressive growth pattern. Now, we have data about the risk of transformation, and interestingly, these two studies, which were published within about a year of each other, showed very similar results, and that is, if you look at the risk of transformation of follicular lymphoma over time, there's a cumulative risk of about 2 to 3% per year. And interestingly, there seems to be a plateau after about 15, 16 years where you don't see transformation events. Now, there might be individual very, rare cases of late transformation. Exactly what the biology is of these non-transforming cases is not well understood, and obviously would be a subject of additional investigation. So I like to just illustrate some cases. Here's a 69-year-old woman with a 5-year history of follicular lymphoma, grade 1-2, had high-risk Flippy disease, initially presented with extensive disease meeting Gelf criteria for treatment. She got R-CHOP for 6 with a PET CR. She opted not to receive maintenance rituximab. She now presents with extensive adenopathy and fatigue. She has 12 pounds of weight loss, about 11% of her body weight. LDH is 346 with an upper limit of normal of 250. And FDG PET scan shows FDG avid adenopathy above and below the diaphragm with SUV max ranging from 6 to 18. There's a 3-centimeter left axillary lymph node with an SUV of 7.4. There's also a retroperitoneal mass with an SUV of 18. What would you recommend? Proceed with dose-adjusted EPOCH for 6 cycles. Proceed with second-line chemotherapy. Refer for a left axillary lymph node biopsy or refer for a retroperitoneal mass biopsy. So 60% of people wanted to refer for biopsy of the retroperitoneal mass. 10% wanted to just go right to chemo, and another 30% wanted to refer for a biopsy of the more convenient lymph node. So this is my take of this case. The clinical presentation is certainly suspicious for transformation. However, transformation is a seminal event. It has a significant impact on long-term prognosis. A biopsy is essential. The left axillary lymph node is convenient, but it's very likely to represent follicular lymphoma. Whereas the higher SUV, more difficult to get at, retroperitoneal mass with the SUV of 18 would be more indicative of an aggressive event. When you use a PET scan, you should never use the PET scan as a biopsy. You use it to direct a biopsy. We'll talk a little bit more about that. And this is actually a real world case. And I did a laparoscopic biopsy of the retroperitoneal mass, and the patient actually had follicular lymphoma and has actually done well on an investigational agent. So always biopsy. So, but when should you suspect transformation? You should suspect transformation if the performance status declines, if there's unexplained weight loss, if there are new B symptoms, and particularly if there's rapid growth or discordant growth. So there's a left axillary lymph node that's growing quickly, but everything else is just growing very slowly. Laboratory findings include an elevated LDH and elevated serum calcium, frequently because of an elevated 125 dihydroxy vitamin D, and then this discordant or increased uptake on an FDG PET scan. So here's some data about the aggressiveness of NHL as measured by PET. So if you look at the range of SUVs, the median SUV for aggressive lymphomas is 19 at initial presentation and 18 at relapse, whereas the indolent lymphomas have a much lower range where they with a mean of SUV max of 7 and 6.3 at relapse, and mantle cell is actually has FDG avidity more similar to the indolent lymphomas. If we look at matched samples, that is a prior follicular lymphoma and in the same patient an aggressive lymphoma, and this is based on biopsies. It's not always perfect that a high SUV means transformation. This is a patient who had an SUV of 13 and it was a follicular lymphoma. That same patient later had a mass with an SUV of 20 and was large cell lymphoma. But you can see that in general, there's an increase from the indolent to the aggressive lymphoma, but not in all cases. And so you have to, if there's clinical suspicion, you got to be aggressive and biopsy that progressive disease, even if the SUVs aren't very high. So PET can distinguish between indolent and aggressive lymphoma. There is an overlap at that lower range, and so you have to be a little careful. But it cannot, and I can't stress enough, it cannot replace a biopsy. What it does is it helps select the site for the best biopsy to give us the clinical information we're looking for. So what about trying to identify transformation when the patient first walks in the door with follicular lymphoma? And this gets to some of the questions that Dr. Leonard posed. If we look at the microenvironment, if there are CD14 positive cells localized to the follicle, well, this is associated with a higher rate of progression to transformation. Similarly, if we with PD-1 expression, that's another thing that tends to be associated, but in the opposite direction. When you see a diffuse pattern, it's more likely to proceed to transformation at some point during the clinical course. I've already mentioned some of these findings of the elevated LDH, advanced age. Presenting with a high FLIPI is by itself a risk. Grade 3 histologies, now grade 3B we consider and treat like an aggressive lymphoma anyhow, but grade 3A tends to have a somewhat higher risk of transformation. Presence of extranodal disease or more than 3 nodal sites. And the patients who progress within 24 months of diagnosis are clearly enriched for transformation. The P53 mutations are seen, BCL6 translocations are seen, and MYC translocations are seen. But interestingly, there does not seem to be a very big impact of therapy. So if you defer initial treatment, that does not appear to increase or decrease the risk of transformation. The early use of or omission of anthracycline from the treatment, again, doesn't appear to impact the risk of transformation. In low tumor burden patients, starting with rituximab versus active surveillance doesn't make a difference, and rituximab maintenance doesn't appear to impact the risk of transformation. If we look at some of the data behind this, we can see that observation, which is the reference here, rituximab monotherapy, there's a slight risk here. The confidence intervals don't cross 1, and the p-value is specific. But if we look at all other treatments, whether it's radiation for localized disease, anthracycline-based or alkylator-based treatment, with or without rituximab, there is no impact on the subsequent development of transformation. There was has been an effort to ask, what is the impact of rituximab on the risk of transformation? Many of us in the field have a gestalt that pre-rituximab we saw more cases of transformation than we see now. But when individual centers tried to look at this, we consistently came up empty, including a study that we did at Memorial. So what was done was about 8,000 patients across 11 cooperative groups were examined with long follow-up and looking at the risk of transformation in this much larger group. So the risk of transformation was 7.7%, which is actually surprisingly low for this group, which is one thing that I always have had concern about these data. Those patients who received rituximab, it was a little bit lower compared to those who did not receive rituximab, and that difference was statistically significant. It was about a 3% cumulative difference over 10 years. If you look at the impact of induction and maintenance, again, there was a suggestion that using rituximab in both induction and maintenance actually was the best in reducing the risk. These data, as I said, are a little bit in conflict to what had been published from single site centers. Now, I think it's partly because this is a much larger data set. If we look at the randomized trial that compared rituximab versus active surveillance, there was no impact in that trial on the time to histologic transformation. These were not statistically significant differences that were seen in this study. It's important to ask, what's the long-term survival of patients with transformation? What you can see here is that transformation is truly a bad event. The median overall survival is less than 2 years. But there are some long-term survivors with 15% of the people, out beyond 10 years without relapse. It's because all transformations are not created equal. We know that if you present with limited stage disease versus advanced disease, if you have not had prior chemotherapy, or you have an excellent response to chemotherapy, these are all predictors of long-term overall survival following histologic transformation. We also know that patients who progress early, but that is the people who are in the progression of disease within 24 months, this group is enriched for patients with transformation. And if we look at these data from Brian Link, looking at the outcome and the survival of patients who transform early actually have an inferior survival, suggesting that biologically the disease was more aggressive from the beginning. So why are people dying with follicular lymphoma? Well, it turns out that still the dominant reason for mortality is lymphoma, and many of these events are actually transformation. If we look at transformed lymphoma, they're overwhelmingly germinal center derived. Well, that makes sense. Follicular lymphoma is a germinal center tumor. And when it transforms, it's transforming from a germinal center disease to a germinal center disease. So 80% of cases, and this is very different than the profile we see in de novo large cell lymphoma. Now, this is based on not gene expression profiling, but on unlimited gene expression profiling rather than extensive large-scale gene expression profiling. Interestingly, transformed follicular lymphoma, it really doesn't matter whether you're germinal center or non-germinal center, outcomes are quite similar. So let's talk about another case, a 64-year-old man diagnosed in 2014 with follicular lymphoma, had low tumor burden disease and was on active surveillance. But over the next 6 years, there was slowly progressive disease. And then he presented with a rapidly enlarging right cervical lymph node. Biopsy demonstrated diffuse large B-cell lymphoma with expression of CD20, CD10, BCL6, BCL2, and P53. There was no expression of MUM1 or MYC. FISH demonstrated a 1418 translocation and a BCL6 amplification, but no rearrangement of the c-MYC gene. FDG PET scan revealed markedly avid nodes in the neck, but with low-grade uptake in the chest, abdomen, and pelvis. The ejection fraction was normal. So what would your treatment recommendation be? R-CHOP ×3 and involved site radiation, R-CHOP ×6, R-CHOP followed by high-dose therapy and autologous stem cell rescue, or R-CHOP ×6 followed by allotransplant. It's interesting, no one wanted to treat the aggressive lymphoma as a localized disease, which is completely what I agree with, but there were some takers for R-CHOP followed by high-dose therapy and autologous stem cell rescue, and a few for allotransplant. So my thinking about this case is a little different. Even though the R-CHOP ×3 or 4 plus involved field radiation therapy would be appropriate for the localized disease, this patient has localized large cell lymphoma, but there's widespread disease and a full course of R-CHOP is appropriate. However, I don't think that consolidation is necessary here. We frequently think of consolidation with either autologous or allogeneic stem cell transplant after transformation, but someone who is presenting with localized disease has never received chemotherapy before, their outcome of their large cell lymphoma is similar to patients who present with de novo large cell lymphoma. And in this is a case of large cell lymphoma where I wouldn't consolidate with high dose therapy. So that would be my approach. So what are the treatment options for transformed? Well, this is aggressive large cell lymphoma. So you treat it like aggressive large cell lymphoma. If they're anthracycline naive, we certainly want to use an anthracycline. So R-CHOP or dose-adjusted EPOCH, either one would be appropriate. RICE or ESHAP or some other second-line therapy if they've had prior anthracycline. But there is no unequivocal standard of care. As I said, patients who have minimal or no prior treatment, they're going to have outcomes like de novo large cell lymphoma and should be treated like de novo large cell lymphoma. But the big question is for the patients who are multiply treated and have transformation, is there a role for consolidative therapy? So if we look at transformed lymphoma and ask the question about the impact of high-dose therapy and autologous stem cell rescue. The fact is that high-dose therapy and autologous stem cell rescue is associated with favorable long-term outcomes in patients with large cell lymphoma. We often think in follicular lymphoma as an incurable disease and that an allotransplant might be better. The NCCN Outcomes Project, Andy Evans looked at the outcome of patients who had received autologous versus allogeneic transplant for transformed follicular lymphoma, and actually showed that the outcomes were quite similar. Now, though the outcomes were quite similar, the reasons for the outcome similarity is really quite different. So, interestingly, if you had a allogeneic transplant, not surprisingly, there was a higher mortality that was transplant related, okay? But if we look at the risk of recurrent disease, the risk of recurrent disease was actually less with the allogeneic transplant. The Canadians did a large retrospective study in transformed lymphoma across the country, looked at 172 patients with proven follicular lymphoma. They excluded patients with 3B. They really wanted true transformation. And all patients received rituximab. In this study, 22 patients had received an allotransplant, 97 an autotransplant, and 53 got chemoimmunotherapy. There was a small difference in favor of autotransplant for both for post-transformation, progression-free survival, and overall survival. This was related to transplant-related toxicity. However, remember, we cannot remove the selection biases here. This is a retrospective study, and patients were selected. If you had extensive bone marrow involvement, you didn't get an autotransplant, you got an allotransplant. So there are issues here, but in general, if an autotransplant can be done, that is the preferred consolidative treatment, and that's what's recommended in the NCCN guidelines. How about just giving chemotherapy alone without consolidation? Brian Link, in his paper on transformation, looked at a large number of patients, 631 patients with follicular lymphoma grade 1 to 3A, found that the 5-year transformation rate was 10%, and that the predictors were an increased LDH, high-risk flippy disease, and advanced age. But the median overall survival following transformation in that series was very good, and the most common treatment was R-CHOP. Median survival of excess of 4 years, and patients treated with R-CHOP chemotherapy. If you look at auto versus allo versus chemo, it looks like chemo alone is as good as an auto transplant in overall survival, maybe a little bit worse in progression-free survival. But again, these are not randomized data, and there is tremendous selection bias here. As I said, I feel that consolidation with high-dose therapy and autologous stem cell rescue is the best option for patients who have had multiply previously treated follicular lymphoma that then transforms, and they need treatment for their transformed disease. This is actually more of the same thing. I'm going to just skip this. This is the same analysis. So, so here is, again, coming back to Brian Link's data about the timing and the use of R-CHOP. That is, should you keep R-CHOP in your back pocket just in case you need it? So in this analysis, again, it's biased, but if you had R-CHOP at the time of transformation, you did better than if you had R-CHOP as part of your initial therapy. However, if we looked at the outcome of newly diagnosed patients with large cell lymphoma and then R-CHOP for transformed lymphoma, as I said, the outcome is really quite similar to de novo transformation. But the problem with these data is that one of the reasons you got R-CHOP prior to transformation is you had more aggressive disease and you had more rounds of prior treatment. So yes, it might be theoretically nice to keep R-CHOP in your back pocket should it, should you ultimately transform. But there are times where that's not going to be possible. And you're going to use an anthracycline-based regimen for the multiple recurrent follicular lymphoma. So we know that there's not an enormous impact of treatment on risk of transformation. Inclusion of rituximab might reduce it a little bit. If you transform, you're going to use a typical large cell lymphoma regimen, which is appropriate for where you are in the course of the indolent lymphoma. If you've had multiple prior treatments, including anthracycline, you're going to use the standard second-line aggressive lymphoma regimen. If you're anthracycline naive, you've had little or no prior therapy, you're going to use R-CHOP. In patients who've had multiple treatments, you're going to think about consolidation. My recommendation is consolidation with high-dose therapy and autologous stem cell rescue. You might want to consider an allotransplant in younger patients, particularly with early relapse. Why? Because they have the worst long-term outcome. Okay, let's turn to a third case. This is a 59-year-old woman with a history of follicular lymphoma, initially diagnosed when she was 57. She presented with extensive symptomatic disease and was treated with R-CHOP with 18 months of maintenance, but the maintenance was stopped because of progressive disease. FDG PET scan demonstrated diffuse FDG avid disease, and a biopsy was obtained demonstrating large cell lymphoma. She was started on DHACs. Repeat PET after 3 cycles demonstrated a partial response. Repeat bone marrow biopsy demonstrated persistent involvement by low-grade lymphoma, and the patient has a haploidentical donor from her daughter. So what would you recommend? Switch to rice and to see if you can achieve a complete response. Proceed with the high-dose therapy and autologous stem cell rescue. Go ahead with an haploidentical allo stem cell transplant, or consider axicabtagene ciloleucel. And this is pretty evenly distributed. Switch to rice, go to high-dose therapy, proceed to a allo transplant, or consider CAR T cell therapy. Okay, so we'll go back to the presentation. So this is my thinking. The patient has POD24, as I showed you from Dr. Link's data, that these patients have a very poor outcome. When you progress for POD24, the population is enriched for patients with histologic transformation, as in this case. The patient has chemosensitive disease, but it's only a partial response. And And there's little evidence that you change from one second-line chemotherapy to a second-line chemotherapy, you're going to get a CR. So switching from DHACs to RICE, I'm not very enthusiastic about that. You could proceed to high-dose therapy, but that's problematic. The bone marrow is still involved by low-grade lymphoma. You don't want to give low-grade lymphoma back. So I think allotransplant is a very good option here. It's completely appropriate. But the one problem is that if you look at registry data about transplant for large cell lymphoma, allotransplant for large cell lymphoma is better if you're in a CR. It's not negative. It's not a foregone conclusion you'll do badly if you have a PR. So that's just the one caveat in this case about proceeding with an allo, but I think that's a reasonable choice here. And then proceeding to CAR T cell is reasonable in a transformed lymphoma. And that's what I would do personally in this case. Okay, so here are some of the data for axicabtagene ciloleucel, if we look at the patients as they were broken out, whether they had large cell lymphoma de novo or either PMBL or transformed follicular lymphoma, and just to know that that population of that population, 20 of them, 2/3 of them, 16 of them had the transformed lymphoma, with only 8 of them having PMBL. So that group is dominated by the transformed lymphoma group. If we look at the outcome of patients treated with CAR T cells, these are exciting data, and with what looks like a plateau in the survival. These data have been updated, and the updated data actually looks quite similar to these data. What about new other approaches other than CAR T cells? Checkpoint inhibitors, BTK inhibitors, venetoclax combinations, or new treatments? Well, there certainly are other possibilities that we could consider, and all of these agents would be appropriate for investigational approaches. So this is my algorithm. If you're previously untreated, I give R-CHOP and I do not use any consolidation at that point. If you've been previously treated with a bendamustine rituximab or CVP for that matter, and you have R-CHOP, well, then the question is, did you progress within 24 months or no, or yes or no? If the answer is no, you could consider observation of patients in a complete response. That's based on the Mayo Clinic Iowa data from their SPORE. But if you're progressing within 24 months, then consolidation with either an auto and allo transplant is appropriate. If you've received previous R-CHOP or multiple lines of prior therapy, and including an anthracycline, then you're going to use a second-line large cell lymphoma therapy, ESHAP, RICE, RDHACs, RDHAP, whatever your favorite is. And you're going to ask the question, is there chemosensitivity or not? If there's chemosensitivity, then consolidation with high-dose therapy and autologous stem cell rescue is appropriate. However, if in the absence of chemosensitivity, an investigational trial is appropriate, or CAR T cell therapy would be appropriate. So with that, I'll turn it back over to John.
Thanks very much, Andy. That was a really great discussion. And I think really summarized the state of the art in transform lymphomas. We've gotten a few questions already, so I'm going to summarize a couple of them. We have about 10 minutes or so for questions remaining. So, Andy, the issue around a patient who has bone marrow involvement at a low level, and would you still not, would you do or not do an auto transplant? So I'm guessing that's a patient who, let's say, has had prior therapy, relapses, get additional therapy and has responded, but still has some bone marrow involvement. How would you generally think about that? I presume that would be a discordant lymphoma in most cases, but your thoughts
Yes.
about that in auto transplant?
Yeah, so I agree with you. I think overwhelmingly what you're going to see is the marrow is going to, if it's involved, it's going to be involved by the indolent lymphoma. Those are patients that we tend to, and these are where these biases come from in the retrospective studies. These are patients that we would tend to take to an allo transplant. Why? Because we know we have a clean stem cell source, rather than reinfusing stem cells, autologous stem cells that have the potential for contamination. So in our practice, we tend to bias towards allotransplant in those patients. I don't know, John, what do you guys do?
No, I would agree, and I would guess that if someone doesn't achieve a CR, they're probably not all that chemosensitive anyway, and so the idea that an auto transplant is going to do the job, if they've got significant residual disease after whatever you gave them, probably an allo would make more sense on that basis as well.
I agree.
Okay. A couple of questions. I mean, you've touched on the composite and discordant lymphomas. As far as the prognosis, if someone has, I mean, I guess let's talk about a de novo patient. I guess that's probably what this is referring to. Say a patient who has large cell lymphoma and follicular lymphoma, perhaps in the marrow at diagnosis. Any thoughts on that as far as prognosis?
Yeah, so there are different types of discordant lymphomas, right? So we have discordant lymphomas that are discordant in the biopsy itself. There's an area of follicular lymphoma, and now there's clear transformation to large cell lymphoma. That patient has a de novo transformation, and I treat them like de novo large cell lymphoma with aggressive standard chemotherapy. Then we have that's the composite lymphoma. Then we have the discordant lymphomas. You have follicular lymphoma in the bone marrow and large cell lymphoma in the node. We have always treated those patients like a de novo large cell lymphoma. Honestly, I don't think, I've always worried that those patients have a higher risk of recurring as follicular lymphoma or some other low-grade lymphoma. But we've not been able to actually demonstrate that. There are certain people, I mean, Wyndham Wilson absolutely feels it's a different disease when you have pure large cell lymphoma versus these discordant marrows. But if we look, there have been a number of retrospective series. Discordant marrows do not seem to have a big impact on long-term outcome.
And then two questions, actually from two different people, kind of asking a similar version of the same thing. A patient who had chemotherapy, had a very long remission, and then transformed. And do you think of that any differently from the standpoint of doing an auto transplant when you get that patient back into remission, or does that long remission perhaps let you watch the patient a little while before you would go straight to an auto transplant?
Well, there I would actually say, what was that long remission caused by? If the long remission was caused by RCHOP, I would probably do second line therapy and high dose therapy and a stem cell rescue. Mm-hmm. But there are some caveats here. So say someone is really fit, they're really healthy, you've done, you got the cardio oncologist involved, they say, Yeah, they had 300 per meter squared of anthracycline, but their heart is great. Um, there's the occasional patient when it's a long interval that we've actually treated with dose-adjusted EPOC because it has a much lower cardiac risk, and we just expose them to the anthracycline a second time, and we do, echoes every 2 cycles, and we've been able to get away with that. Remember, EPOC was originally designed as a regimen for relapsed large cell lymphoma. So all of the patients had prior exposure to anthracycline. So we know it is a safe regimen. So if it's a very long interval and the heart is healthy, I have done that and with good outcomes.
Any thoughts on mini allo? I mean, I'm guessing when you talk about allo here, mini allo would be more or less in the same.
So it's exactly the same way we would use allo anyhow. If someone's in a CR, we're going to use a reduced intensity transplant. But if they're in a PR, then we would typically use a full allo.
And then a question about CAR T cells and other criteria, age, other things that would interfere with somebody's ability to get CAR T cells, just generally.
So I only talked today about axicabtagene ciloleucel. However, we actually have data in transformed lymphoma from Tisagen leclucel and from the unapproved lisacabtagene maraleucel. And lisacabtagene maraleucel is emerging as one of the safer drugs we've treated a number of patients as outpatients, and a good proportion of those have never been admitted. Here we have a safer, gentler CAR T cell, and that is going to open it up to patients with comorbidities, to older patients. As long as we can control the toxicity associated with CAR T cells, we're going to be able to, use these treatments in a less favorable patient population.
And then one last question, your experience with double hit lymphomas coming out of follicular lymphoma. So a patient who's on watch and wait and then turns into a double hit lymphoma, or had prior therapy and turns into a double hit lymphoma with a follicular background.
So those are actually 2 different patients. The patient who, because remember, they all have the 14-18 translocation, 90% of them have a 14-18 translocation, and translocation of MYC is associated with transformation. So those de novo double hits, they do just as well or just as poorly, depending on your point of view, if you're a half full or half empty type of person, as a de novo double hit. However, if you've had multiple prior treatments, in my experience, the translocation of MYC as a late event after multiple prior treatments is associated with outcomes that are measured in weeks, not months.
Yeah. It'd be interesting to know how much of the poor outcome historically in transformed lymphoma relates to that versus other scenarios. I don't know that some of the historical data has separated that out, but it would be an interesting.
I agree with you. I think it is an interesting question.
Yeah, great. Well, thanks, Andy, for a really great discussion. I want to thank our audience. Also, a reminder to visit oncologycaseclinic.com. You can register for our upcoming webinars and view the past webinar archive. And there'll be a recording available of today's session, which has been great, with downloadable slides. This will be also at oncologycaseclinic.com in about 2 weeks. And I'll invite you to join us next month on Wednesday, July 8th. We'll have Matt Davids from Dana-Farber giving an update in chronic lymphocytic leukemia. Thank you all very much for joining us. All right. Have a great day.
Thanks, everybody.